we consider health equity in behavior change approaches to help reduce health inequalities. Hi, I'm Katalin, your host for this episode, and I'm meeting Dr. Lisa Newson and Dr. Oladayo Bifarin, two experts in the area, to find out more. Hello there. You're both researchers as well as clinicians and both work at Liverpool John Moores University. Would you like to introduce yourself? So Lisa, why don't you go first?
Thank you, Katalin. So I'm Lisa Newson. I'm a health psychologist and I'm a reader in applied health psychology at Liverpool John Moores University. And I'm really interested in the application of health psychology and behavioural science into practice to change the experiences of patients and the healthcare system and improve the way that healthcare messages and healthcare services and interventions are delivered and how they are received. So that's my focus. And I work quite broadly across conditions from obesity, cardiovascular disease, diabetes, but also in the realm of public health interventions and trying to think about how can we improve health promotion and prevention of ill health as well.
Thank you. How about you, Oladayo?
Thanks, Kathleen. I'm Oladayo Bifarin. I'm a clinical academic, mental health nurse by background. So a senior lecturer in mental health nursing at Liverpool John Moores University, the research and effectiveness lead at Mercy Care NHS Foundation Trust. And I should also say that I'm a senior research leader within NIHR. My sort of area of work is very much around examining existing mental health care pathways, particular focus on reducing health inequalities. I'm very passionate about supporting underrepresented disciplines to have a voice in research because that is where we can make real change happen.
Thank you. This sounds very interesting. And I have to say I'm personally really interested in this area as well. So this should be a really good conversation. So let's dive in then. How do we change behaviour? And what do behaviour change interventions do?
I would like to say that in the words of change behaviour, that change as a word and a concept is tricky for people. It's an alteration of the status quo and it makes people feel uncomfortable. So change as a word and as what we're trying to do with interventions or with people, it can be tricky. And then behaviour in itself also can be complex. So how do we change behaviour? It's not easy, but I would add on to that, how do we change behaviour and keep it and sustain it and maintain it is kind of the thing. So behaviour interventions themselves, they do things to change a specific behaviour or a habit. So it might be something like to stop smoking, to increase physical activity, or it might be to take medication as per the prescription or some other behaviour. So an intervention is designed to use techniques or strategies to promote that behaviour change that I've just mentioned in those examples. And so an intervention might focus on an individual aspect like changing motivation, trying to improve self-regulation, or it might target multiple components of behaviour change. And where I say components, it's useful to think about behaviour change interventions in the context of a framework or a model or a theory. And so I'll just briefly mention the COM-B model. It comes from behavioural science and health psychology. And COM-B is capability is the C, the O is opportunity, and the M is motivation. And if we can target the COM, the capability, the opportunity, the motivation, either an individual aspect on that or collectively, then this will help shape and change behaviour. So capability are things like maybe it's psychological capability, so it's education and skill building, or maybe it's physical capability like access to resources to help initiate the behaviour change. Opportunity might be things around our environment or our social factors, our social environment. And so in a behaviour change intervention, we might think about social networks or providing local environmental incentives to change a behaviour. And then the last one, motivation, that I mentioned, we can think about what we refer to as intrinsic or extrinsic factors. So highlighting the benefit of a behaviour change, thinking about assessing achievable goals or incentives to reinforce positive behaviours. So that's very briefly a basic model that can help us think about what the components of how do we change behaviour. Well, we do it by addressing some of these components, but ultimately we do need to tailor interventions to meet the individual needs and individual contexts as well. So that's sort of where I'm going with that. The challenge of having something that's planned and designed and systematic, but also we need to keep the people, the individuals at the heart of what we're doing and tailor it and personalise it to their needs as well.
Just reiterating what Lisa said there, that Drawing on existing evidence, it's important that we see health-related behaviors as people's actions. So when you talk about change, let's think of people's actions. And for me, as a mental health practitioner, I'll go further and say these are symptoms, the way people react to something. And I think having the understanding, then it's about us thinking of that person. And this will be unique. And that's what makes it complex, because as human beings, we are complex.
What I'm gathering here is that it's important to have the theory behind it, and we have to make the intervention systematic in order to target those conditions of capability, opportunity, and motivation. But we must not forget the person or the individual. It should be in the center of our attention. Then why is it so difficult to change health-related behavior, and especially, as you mentioned, maintain that change?
As Lisa mentioned, it's how do you keep that behavior? How do you sustain that behavior? And I think here is looking at health-related behavior through the intersectionality lens. These complexities tends to be amplified when you think of intersectionality, particularly the various forms of social stratifications. You look at race, gender, class, sexuality, age, and all the rest. They don't exist in isolation. They interact with one another, and that's where things get compounded. So for me, looking at this, intersectionality actually can add to the complexity of behaviors, which is why the individual must be at the heart of that. It's difficult because habits are ingrained, very challenging to break old habits and form new ones. For example, when you're changing from one behavior may require addressing underlying factors. And for you to do that, you've got to make adjustments. Now, that's a lot. That's a lot of ask. For example, as you've seen in media recently, government trying to ban smoking. How can someone stop smoking? But again, are we thinking about the impact that might have if they decide to stop on their mental health? And that's where one size can't fit all. And the way A will respond in terms of coping will be different to how B would do that. How do we get everyone along? And again, second point I want to touch on there is, as human beings, it's difficult to get people to think of the long-term benefits. It's the immediate gratification that, you know what, I just want to leave. I just want to leave now. The future can sort itself out. And that's where, again, it's challenging, which is why the COM-B model comes into play, understanding that individual capacity in terms of the opportunities that present us and thinking of how can we motivate them, perhaps incentivizing or actually disincentivizing as well. The big one for me in this particular area is lack of support. And if I'm asked to just mention just one, I would say time is a big one. We live in a fast-paced world today, and is how are we helping people to stop and think and reflect on their behavior? Because unless people are able to stop and reflect and think and actually stay in circle where new ideas will come, it can be very difficult to change behavior, let alone sustain that behavior.
Is there anything, Lisa, that you want to add to this?
As he's mentioned, those social determinants, the complexity of behaviour, thinking about, the resources that people have and what's going on around in the environment, in policy, in practice, socially, they're all key aspects to change behaviour. And Oladayo's mentioned this, but as a psychologist, I'm really kind of jumping on it, because I think if we think of behaviour change, and I mentioned the COM-B, like an equation, COM equals B, COM equals behaviour, the mechanisms of action. So if we just step back a bit, we're always talking about how do we get people to change the behaviour? What do we tell them to do? What resources do we need to give people? How do we change the environment? How do we do this? But if we just stop and first think about the mechanisms of action, so what I'm getting at is, what are the psychological factors or the changes that people go through to initiate a behaviour change, or indeed to sustain a behaviour change? Because as we change our behaviour, we then start to change our habits. This changes our beliefs, it changes our attitude, it changes the way that we interact with people around us. Often people might have what we call a resistance to change. Maybe they've got a fear of the unknown. What's going to happen? How is this going to last? Or a fear of failure. I've tried this before and it didn't work, so why should I try again? Or I'm setting myself up here to not achieve. And there's that. And then on top of that, there's the emotions. So how do we help people regulate their emotions as they're changing behaviour? So, mentioned they're stopping smoking. Well, actually, if smoking's used as a coping strategy and a coping tactic, how do we help people manage coping better in a different way? when they change their behavior to stop smoking? How do we help them to change their social network and their environment and those relationships, or any anxiety that they might be having, etc., etc.? So for me, it's kind of a step back before we initiate the behavior change to ensure that psychological change is well managed. And I think as a health psychologist looking into behavior change research or interventions, or even in the healthcare system, so often I think this is the step that is often missed. There are some examples of good practice. I'm not saying it's not in healthcare practice, but often I think people, health professionals, interventions, people in the public, everybody jumps towards, let's change the behaviour, what do we need to do, as opposed to let's help people develop their psychological skill, evaluate their emotion and their needs.
That sounds very complex, actually. And I wonder, how does this translate into interventions? So how do we deal with these challenges when designing and evaluating behaviour change interventions?
Yes, and that is the challenge, that behaviour change itself is complex. And as already mentioned, we are human beings and we're complex. And the process of, as we change behaviour, things change. So that's complex. So designing interventions has to accommodate this fluidity, if you like, of behaviour and life, and fitting into how people do things and individual differences. And that can be challenging to design an intervention that perhaps we're wanting an intervention to be generalised across a big population. But actually, some of those challenges coming back to cultural needs, social needs, issues around gender and equity and equality, and how do we meet the needs of the individual. So these are things that we need to think about when we're designing interventions. And for me, one of the things is to, first of all, encourage researchers to stop and reflect. As a health psychologist, reflective practice is what we do, but reflect in the way that, is this meaningful for the people that are going to be interventioned? These are the participants, the service users, the stakeholders. And that's where aspects like co-design come into intervention research and intervention design. So actually, quite often when we look at interventions, it's designed for the masses. Well, how have we assessed that in terms of designed it for the masses? Have we talked to people? What's acceptable to them? Do we use the right language for them? Do we use the right environment for them? Are we using the right resources for them? And I think that's one of the key things. One of the other things is, when we design interventions and we put them out in practice, how do we assess them? And how do we make comparisons to systematically understand what's needed? And I think we've got a way to go with doing this in research. And of interest, so my colleague, Dr. Evans, recently completed her PhD at Leeds Beckett, and part of her PhD was to evaluate the NHS England low-calorie diet programme, and we ran a fidelity and adaptation study. So fidelity, looking at, does the intervention that's delivered in practice with the patient group, do the services deliver it as it's been designed? And of course, when we've looked at that and evaluated that, and we've published, there's 2 papers related to this PhD that relate to what I'm talking about. One is in diabetic medicine. Can the delivery of behavioural support be improved in the NHS low-calorie programme? An observational study of behaviour change techniques. And the second one is in the British Journal of Diabetes. How is the NHS low-calorie diet programme expected to produce behaviour change to support diabetes remission? An examination of underpinning theory. And what's interesting, the reason I brought these up is, even when we design interventions, so it's in the service spec, it's in the intervention protocol, when we look at what happens in practice, the fidelity isn't there. So interventions are delivered differently. And that's not necessarily a criticism, because the delivery staff are trying to personalise it. They're trying to tailor it to the individual. So I think one of the things we need to start thinking about is, how do we design a good intervention? But actually, we need to help transfer the research interventions into practice so that we can help staff do that tailoring and personalising in a very meaningful way without losing the quality of the intervention.
I think Oladayo will have something to say about this, how you can actually use these interventions in practice.
These are fantastic points. And I think that is where my role, for example, within my trust sits. How do we increase what we consider to be underrepresented disciplines in research, your nurses, your allied health professionals? How do we help them increase their research capability? Because as much as we can design the project with people at the center, when it comes to the point of translating that knowledge into practice, it's having the right hands to take that and implement. And that is a big challenge for us, I must say. And thankfully, from leadership with the likes of Ruth Endicott at NIHR, who's the director, we are seeing more policies coming through now, putting it out there that we must make sure we carry along this workforce with us, because emphasis for a long time has been placed on patients, carers. We forget staff, because yes, staff might be able to get on daily basis, but where is it time for them to take a step back, attend that presentation? Because how are they going to find time to read that journal that Lisa just mentioned? Why can't we bring that author into an organization to present that to these people and they take that into their practice? And I'm doing something like that very similarly. I'm hoping to do something like that in a short while. Submitted a small pool of money to bring researchers into my trust, disseminate their key findings, and let's evaluate that. We need interventions around knowledge mobilization, because a lot of money goes into research, it gets published, and then what next? Policymakers, they take it, develop something quite ambitious, but you know what? It doesn't translate into practice.
Yeah, that sounds like the challenge, doesn't it? We discussed quite a lot about what we need to include into interventions, but also how to take into consideration the context that intervention takes place in, and how important it is the individual in the center of that intervention. What I would like to ask you, and we always ask this from all of our guests, is to tell us about your vision for the future in terms of behavior change science. What is it that you would like to see?
That's a really good question. I am the chair for organisational liaison committee of the International Society of Behavioural Medicine. And my future, my ambition, the work that I'm doing to promote this across the world is really to think about how we can help integration of behavioural science, behavioural medicine, health psychology into more health disciplines, both in academia, even at LJMU. Much of the work that I'm doing at the university is working across multidisciplinary professionals, not just health professionals, but in the business school, in law, in education. And then the same in healthcare. So I want good behavioural science, both in terms of understanding research and what's happening, but also to bring health professionals more into the fold of academic research. And as a health psychologist, and having worked in my career as a health psychologist and in the NHS prior to academia, I understand those complexities and the practice and the pragmatic nature of dealing with healthcare, the here and now, and working with patients. And I think that's an important aspect that we need to bring into our research, our academic work, and our intervention design and behaviour change, because behaviour and behaviour change is real. It's a moving beast, and we need to research and experiments and design. That's all great, but these are academic things. So having a paper or publication, okay, maybe as an academic I should be promoting that, but actually this is about real world change, making a difference. So we've got to kind of get in at the ground level with real people, get real people, patients, stakeholders involved in our research plans, not piecemeal. I know this is more common these days that people are doing PPIE, patient public involvement and engagement. As an engaged scholar myself, I still think it's a little bit piecemeal. It's kind of a little bit tick box. Oh, we've done that aspect, let's move on. But I'd like more of that. I'd like more involvement in even conducting systematic reviews and meta-analysis, like what's their interpretation of the evidence that's coming through? Is this real? So my vision is more engagement, more promotion of behavioural science, and that this is not behavioural science washing. Let's just kind of, brush over and stick a bit of this in. Let's really think about how do we help people's psychology and emotions to change as their behaviour change? How do we help people to manage this in a very constructive way? And from a research and academic angle, how do we work as engaged scholars to get the best of both worlds, as opposed to that kind of traditional siloed working?
Thank you. That sounds very promising. What about you, Oladayo?
A lot of things I would say, I'd like it to mirror Lisa's comment. Particularly, I think if I start from where I stopped, that at the moment, it seems that it's widely accepted that it takes 15 to 17 years for bench to bedside sort of translating research into practice. And that is just not good enough. We need to implement best evidence-based interventions at scale. We need to integrate behavior change principles into healthcare systems. We need to focus on sustainability, because it's not just about now. It's about thinking of the pound, not the pennies. We need to be able to have these conversations. We need to be able to have people in our space that think differently. And for me, this is where your clinical academics needs to be at the heart of this. They must be able to complement clinical operations managers. A recent report was published in Northwest, I think, by the NHS R&D, and a key part of that is you've got clinical academics around, but they struggle in terms of their identity because it's not one thing. I'm not saying it should be one thing, but when you're a clinical academic, people see you as you're doing too much. But because you're in a clinical settings, you see how much gap we have, and you want to try and complement that as much as possible. But traditional researchers sit back and see that as, oh, you're just doing too much. No, the scale of the problem is massive. And until we have the right hand on deck to complement, it's like a jigsaw. You've got your service managers, operation managers, you've got these managers. What needs to happen there is what blends the gap between practice and clinical delivery. And for that, what drives me is making sure that these interventions are tailored. For them to be tailored, we must ask the right questions. For us to ask the right questions, we must have protected time to actually have radiant conversations, not binary conversations. And for that to happen, we must have people who have a strong sense of identity in terms of their profession. In mental health nursing, we have a lot of evidence out there that we need to do more with our education. When our students qualify, they get on the wards, they're mental health nurses. Research is more like an add-on. Majority of staff within, for example, the NHS, majority are nurses, for example, of course, with AHPs. They spend the vast majority of time with patients. And if we want to get that research into that space as quick as possible, they must be involved right from the start, as much as we want to also involve public and patient. For me, it's going on for long now that we're prioritizing patient, prioritizing public. In my opinion, we tend to forget staff, and that needs to improve urgently.
Okay, so I add that to my list as well. So not just focus on the individual and the patient, but also the practitioners and the clinicians, all the staff that put in the hard work. Well, thank you very much for your input today. It was really interesting, and I think you've given us a lot of food for thought. So thank you for coming.
Thank you for having us.
Thank you. Thank you for the invite.
Lisa and Oladayo gave us an insight into why health-related behaviors are difficult to change, and how the wider social, cultural, and structural context and the intersecting social determinants of health are the roots of that difficulty. Once again, the importance of involving patients and the public openly and transparently was raised, especially when examining how to help people with changing health-damaging behaviors and what else needs to be considered alongside that. Let us know how a behavioral change approach fits in with your work using #ImplementEquity.